Good afternoon, everyone. Welcome to today's informative session on pregnancy's hidden impact, cardiovascular and dementia risk. My name is Kuratula. I am the Executive Assistant and the Membership Coordinator at the Council of Agencies Serving South Asians, CASSA. We are so pleased to have you all with us. Before we begin, I would like to take a moment to introduce CASSA, the Council of Agencies Serving South Asians is a social justice umbrella organization. CASSA has over 120 organizations that offer direct and indirect services to the South Asian and other racialized communities. These organizations provide a range of services, including social services, health related services, educational, sport, cultural services, and much more. At CASA, we serve our member organizations through advocacy, research, capacity building, training, and development of resources. A couple of housekeeping notes before we begin. The session will be recorded. The resources and materials from this session will be shared with you via email after the session. Attendees are welcome to type their questions into the chat at any point during the session. A dedicated Q&A session will begin at 2:10 p.m., during which our speakers will respond to your questions. With that, now I am delighted to hand it over to our co-organizer, Monica Perry. She will introduce herself and will provide an overview of the project Crowning Us. Over to you, Monica.
There, thank you. I was muted. You think after many years of using Zoom, I have this figured out. Anyway, welcome everyone to our session today. I'll just do a little bit of an introduction. Chirat already mentioned we're covering pregnancy's hidden impact, cardiovascular and dementia risk. I just want to do a small land acknowledgement looking at equity, allyship, and land recognition. I certainly acknowledge the structural inequalities that have disproportionately affected women, people of color, gender diverse individuals, and people living in underserved communities. As a white settler myself on this land, I believe I have strong allyship against racism, xenophobia, and other forms of human rights violations. I recognize my responsibility to the original and ongoing caretakers of the land in which we are meeting today, which is the traditional and unceded territory of the Algonquin people. I also invite those of you joining us in a digital space today to reflect on the ancestral lands in which you are physically located, and I've included a link here. For this webinar, please do what's best for you and engage as any way you feel comfortable. So as we sort of transition into this very important presentation, I just have a couple of things for you to sort of think about as we sort of head into the lesson today. So when did you last reflect on your own health, heart and vascular health? Within the past week, within the past year, not recently, or I'm more focused on others' health than my own. And just something else to think about as we transition into our presentation. Which of these can be a warning sign of heart disease that is often overlooked in women? Nausea or lightheadedness, shortness of breath, jaw or neck pain, or all of the above? So we know that heart disease is on the rise and is the leading cause of death for women worldwide. And I think if you look at the graph on the right, Canada and the US, Canada is the solid red line and the US is a solid blue line. Our mortality rates are increasing and increasing in younger women. And that is one of the drivers of this presentation. This is a nice visual, I think, really to show how risk factors really carry through across the lifespan, from getting your period to depression to using contraceptives, things like rheumatoid arthritis, chronic kidney disease, and menopause. And today we are focusing on pregnancy-related risk factors. So crowning us, just a few slides on this, stands for cardiovascular risk across the lifespan in women, intersex, gender diverse, and other underserved people in Canada. We are a Canadian initiative focused on equitable cardiovascular health. centering women, intersex, gender diverse, and underserved populations. We're promoting health across the lifespan, and we're challenging gaps in representation, treatment equity, and bias. So Crowning Us has three major objectives, and that is to share knowledge about cardiovascular risk in women, build capacity to improve cardiovascular outcomes for women through community and individual partnerships, and to ensure equity, diversity, and inclusivity in governance and decision-making in all the work that we do. This is a little visual about Crowning Us. Really, it's a group that got together in the spring of 2025. We're planning, and you can see we're hoping to host a workshop in February 2026, which is Heart Month. And part of our journey is sharing knowledge about women's risk, cardiovascular risk, and hoping to gain some input and some others who might be interested in helping us on this journey. This is some work that we did, just quickly showing you it was a rapid review to see how communities and patient partners were engaged in women's health, heart health research. And we really only found one community study that engaged a community in women's heart research, and that was in 2007. So we really need to have the voice of those living with heart disease and stroke disease helping us make change. So the learning outcomes for this presentation illustrate real-life pregnancy experiences of a South Asian woman, discuss pregnancy-related risk factors, and examine pregnancy's hidden impact to heart and brain health in women. And we've already talked about the questions, and that's everything I need to share. So welcome.
Thanks, Monica, for sharing Crowning Us project details. And now it's my pleasure to introduce Juhi Patel. She will be sharing her lived experience with us today. Please join me in welcoming Juhi Patel. Juhi, over to you.
How are you today? I'm going to share my experience
Sorry, sorry to interrupt, Juhi. We can't hear you properly.
Um,
I wonder if shutting off your video might help. Although I like looking at you, but it just might help with the voice.
Yeah.
okay, let me stop my video, I guess. Can you hear me now?
Yes.
Okay, all right. So, hello everyone. My name is Juhi. I'm 34 years old and I'm mother of two kids, 8-year-old son and 6-year-old daughter. I'm going to share my experience today of my pregnancy and how I was affected by gestational diabetes. So, my first pregnancy was okay. I had a sickness as usual. 8 to 10 weeks, I had a morning sickness. I was throwing up in the morning, and then after a little bit of time, it went away. Everything was good until doctor asked me to get a test done. That usually I think it gets done in I think after 20 weeks or so, and they give you a drink, some kind of a drink that has sugar in it, and then they ask you to wait for 45 minutes to an hour, and then after that they do a test, and then I got call from doctors saying that I got gestational diabetes, and the doctors asked me to then watch my diet. They refer me to dietitian as well. They give me uh, a portion of meals, and so they gave me the presentation of how the portion of the meal should be, and then how I should be looking at carbs that I'm having in my food. um, I was and it was hard for me to, taking care of my diet while I was working full time as well. So I also had to track down like whatever I eat, and then I also had to monitor my blood sugar after each meal, like with the monitor, like the diabetes monitor, and every time I had to poke my fingers and take a blood drops, put into the monitor, and I had to write down like whatever the sugar numbers, and like I had a chart like in the morning, afternoon, and evening after every meal. I had to track down all my sugar numbers. They usually were between 10 to 13, so it was like more than what normally it's supposed to be. And as an Indian, we eat lots of carbs, rotis, and rice, and like all those things are common in our diet. They asked me to cut down on those things, and I had to add more leafy vegetables and also eat lentils, beans. And I was eating meat that time, so I was like also a portion of a meat as well. Um, at the time of the delivery, then my son's head was big, a little bit big, and because of that gestational diabetes. So when we have gestational diabetes, doctor has told me the baby's size get bigger because of it, and so it was hard for me to push the baby out. I had like some problems after that too. Like I had sciatica, one of the things I had um, uh, until like few weeks after I delivered the baby. The delivery was normal, but doctors had to use vacuum to pull the baby out because the baby's head was a little bigger than it normally should be. Um, so that was my first pregnancy and delivery, and then I got pregnant again after uh, both my kids have 1 year and 9 months gap in them. So in my second pregnancy, they found out again I had a gestational diabetes. This time they referred they had to refer me to the diabetes specialist because it was a little bit higher side than it was in the first pregnancy. Same things I had to do. I had to keep my diet, track down all the numbers, book myself, and put down all the numbers of the sugar. And this time, like because they referred me to diabetes specialist, this time they were a little bit strict with my diet as well. So I had to. The doctors asked me to actually take insulin this time, but I was scared of like poking myself, and now like I had to inject myself with those insulins. So then then I requested doctor that like if I can just like strictly keep my diet like as it's supposed to be, and then doctor asked me to walk 30 to 40 minutes after each meal. So I had to eat and then like wait for 10-15 minutes, and then had to walk for half an hour to 45 minutes. And I was working full time too, so I had to take permission from my manager, and they were like very nice staff there, so they gave me permission after after lunch I had to walk. So it took me a little longer for lunch time. Um, so that was my second pregnancy, and basically postpartum was a little bit harder this second time, um, and I'm thankful of my family because it was a big support. I was getting upset all the time and wasn't feeling well. It messed up all those hormonal changes in my body. So but I have a very supportive family, so I want to be thankful to them. And I also want to say good luck to all these pregnant women, and hopefully, this my experience will help everybody in the future. Thank you.
Thanks, Juhi. Your perspective help us to better understand the real world challenges and opportunities within our communities and remind us that why it's important to work collectively. Thank you so much, Juhi. Now it's time for our first presentation, but before that, just a reminder, like if you have any comments, questions, or any concerns, please feel free to send a chat and we will be monitoring that as well. Um, and now it's time for our first presentation. It's my pleasure to introduce our first speaker, Shahin Jaffer. Dr. Shahin Jaffer is a clinical professor at the University of British Columbia in Vancouver, Canada, and holds a master degree in healthcare and epidemiology. She has been practicing as an internal medicine specialist for over 25 years. Her main areas of interest and expertise are weight management, diabetes, and cardiovascular health. She regularly presents updates in clinical medicine to healthcare professionals and general public, not only in Canada but also at universities and health services in East Africa and Central Asia. Dr. Jaffer has received awards for leadership and women's heart health advocacy. Most recently, she received the King Charles III Coronation Medal for her significant volunteer contribution and service to Canada. The presentation will discuss women's cardiovascular health, key risk factors, and the future impact of pregnancy related outcomes. Shahin, over to you.
Thanks so much, Kurat. Can everybody hear me okay?
Yes, we
Okay, and
can.
thank you so much, Juhi, as well, for that courageous sharing of your lived experience. And thank you to CASSA and all the other sponsors. And Monica are crowning us. It's a wonderful project. So, as was mentioned, I'm going to talk about the future development of heart disease in women who have certain complications in pregnancy. But first, I'd like to acknowledge that the land from which I'm presenting today is the traditional, ancestral, and unceded territory of the diverse Indigenous peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I speak with much gratitude and humility and pay respect to the First Nation, Métis, and Inuit peoples all across Canada. I also want to provide this disclaimer, and that is that the information that's provided in this session should not be considered as medical advice and is not intended as a substitute for medical professional help or guidance or diagnosis or treatment. Always please seek the advice of your physician or other qualified healthcare provider with any questions you have regarding your medical care. So we're going to have three polls, and I'll just kind of go through this. We're using a Mentimeter, and then so this is just a practice poll so that the audience can kind of get used to doing it. So Kurt will shortly put up the poll, but I will just read the question. So which for the audience. So which one of the following statements best applies to you? And I think we have five options. And number one is I think Mentimeter is fun and interactive. I have no idea what Mentimeter is. Mentimeter counts the number of candy mints I eat every day. I have used Mentimeter before, and I have not used Mentimeter before. So I'm going to stop sharing, and I'll ask Kurt to put up the polling question on Mentimeter so we can all just practice responding to it. Thank you. So Kurt, could you explain how to go about answering? I think you're muted as well. Sorry.
I'm sorry. Yeah, so the thing is that I will be posting a Mentimeter code into the chat as well, but I will also show you a barcode where you can just scan it and can sign into the Mentimeter directly. So I will be just sharing my screen. So here is the barcode. Please try to scan it. And you will be directly logging into the Mentimeter. If there is any issue, please feel free to send us a chat or use the hand gesture. So we are seeing the responses. Shahin, do you want to go ahead?
Maybe just a few more seconds. How many people do we have attending, correct?
It's I think
Okay. So I think probably most people have had a chance, and I see that some people have never used Mentimeter before. So hopefully, this practice will, help us for the next two, which are the actual mini mentor questions for this session that I've developed. So hopefully, we'll be able to get the responses. So I'll just start sharing my slides again.
yeah. I will stop sharing the screen.
Sure. Okay. All right, so I'll just move on here. All right, so the learning objectives are that by the end of this presentation, I hope that you will be able to understand how common heart disease is and that you will be able to share how symptoms of heart disease can be different in women, share it with your families, your friends, and also be able to explain the risks for heart disease. And we'll talk about the traditional risk factors like high blood pressure and diabetes and smoking. But then we'll also talk about what many people, including our, physicians, our nurses, our midwives, many healthcare professionals are not up to date on some of this information that I'm going to provide you with this shortly. So these would be the sex and gender related, as well as what we call the under-recognized risk factors for heart disease, especially in women, but also some in men as well. And lastly, I hope that you will be able to understand the pregnancy-related conditions and their future cardiovascular risk, not just in women, but also in their offspring. So, heart disease, since 1990, so over the last, 30 years, has been the number one cause of death globally. And you can see that here in 1990 and then 2021. And even today, heart disease is the number one cause of death. And then the most recent data have shown that neoplasms or cancers have dropped from second to third, and respiratory infections such as TB have become the number two cause of death. Now, this is globally. Now, Monica already showed you this slide, and when somebody shows you this slide twice in a presentation, that means it's really important. So, cardiovascular related death in women is rising in Canada. And this slide, let me guide you through it. So these are death rates. These are not rates of having heart attack or stroke. These are actual death rates. And so the Canada is the dotted line, which is Canadian males, and then the straight line in red is Canadian females. And then these are all high income countries, so Australia, United Kingdom, but we'll just also look at maybe the USA, which are in this teal greenish kind of color. But you can see that for Canadian women, there's a rise, an ongoing, continuing rise in the number of deaths from heart disease in women. In men, the red dotted line, it seems to have tapered off, but you can see that in women in the US, in Canada and Australia, the UK, these solid lines, they're continuing to go up. So again, heart disease not only is the leading cause of death for women worldwide, it's actually the leading cause of early death. So in women between the ages of 35 to 55 in Canada. And also you can see now, hopefully, that it is continuing to rise in these countries. Now, what do we mean by heart disease? Heart disease, you may have heard being described also as cardiovascular disease, and it's really a general term for a variety of conditions that affect all the blood vessels in our body. So, not just our heart, but our brains, our arms, our legs, in the abdomen as well. And this, you mostly have heard about heart attack and stroke. So, these are all heart disease, heart rhythm issues, valve disease. And what happens is this process of atherosclerosis, where you get this plaque buildup in the arteries. And this can start again in our early 30s, where you get proteins and fats and other inflammation in these arteries, and they build up. And sometimes this little plaque can rupture, developing a clot which blocks your artery. Or this plaque can continue without rupturing, but it ends up being so big that it blocks the whole artery. And that cuts off the circulation, leading to the heart attack or the stroke. And the burden of heart disease in women is quite high. It's really not only a man's disease. And here are some statistics for you from the Heart and Stroke Foundation and other publications. One Canadian woman dies from a heart attack in Canada, now we're talking, every 20 minutes. So in the next hour when we finish this session, 3 women would have died from a heart attack or a stroke in Canada. And in 2022, heart disease killed 7 times as many women as breast cancer. And women living with diabetes are 3 times more likely to die from heart disease when compared to men. Women are not referred to rehabilitation programs as often as they should, less than 50%. And women are 60% less likely also to regain independence, going back to their usually activities of daily living after stroke. And unfortunately, more women, twice as many women, go to long-term care facilities after their stroke when compared to men. All right, so let's do our second poll. Let me just go through the questions first. So which of the following are risk factors for heart disease? So your choices are number 1, high blood pressure, high cholesterol, and smoking are risk factors. Number 2, depression. Number 3, rheumatoid arthritis. Number 4, being of South Asian origin. Number 5, preterm delivery, high blood pressure, or diabetes, both in pregnancy, or only one, number 1, or only number 4, or the last choice is all of the above. So I'll stop sharing, and Cora, thank you for putting up the Mentimeter slide again. Does everybody have the QR code, or some people might have, there we go, perfect.
The code for the Mentimeter is in the chat as well. So please feel free to use that or scan the code.
All right, we'll give it just 30 more seconds. So how many votes should we have, Kurt, approximately? Like 15, or how many people? We have 18 people. So so maybe when we get the QR code, so I can think it's 0 on that first option. Okay, so we've got most people who have voted. So all of the above, this is great. The majority of people have said all of the above. So yes, all of these are risk factors for heart disease. So that's perfect. Thank you for participating in that. And we'll talk more about all of these conditions shortly. So I just want to share what a risk factor is. So risk factors are characteristics or behaviors or traits that increase the chance of developing that disease. It doesn't mean that you necessarily get that disease or that health condition, but it increases your chance or your risk of developing that condition. Now, risk factors for atherosclerosis or heart disease or stroke can be categorized as modifiable, which are orange in color, or non-modifiable or genetic. So you can see that high cholesterol, high blood pressure, diabetes, being overweight, or being a person with obesity, having an unhealthy diet, smoking, or being inactive, these are all considered as modifiable risk factors. And then there are conditions such as a family history of early heart disease, one's age, one's sex, and other factors, proteins that cause clots. These are all factors that really we cannot change. So we really need to focus on these modifiable risk factors, which are actually 80% of the risk factors. So the good news is that we can affect our future development of heart disease by targeting these risk factors. So we've talked about these traditional risk factors already. What is not also known is that these risk factors, they are actually a more dangerous risk factor in women. They have higher death rates and higher illness and hospital admissions in women compared to men. So it's, again, men also get these risk factors, but it's actually a more worse outcome in women. Let's focus now on these female-specific as well as the under-recognized risk factors that I've listed here, but we'll talk about in a bit more detail. So Monica showed a different version of this slide, but heart disease in women begins really, really early, in fact, at the time of conception. And this relates to abnormalities with regards to the placenta, which we'll talk about more in the next slide. And then if one has irregular or early periods or a family history of heart disease with pregnancy complications, polycystic ovaries, or what we call these maternal placental syndromes, like preeclampsia or eclampsia, gestational diabetes, gestational high blood pressure, or even preterm birth or miscarriage. These are all coined maternal placental syndromes. And these are risk factors for heart disease. Even rheumatoid arthritis is one of the polling questions, or lupus. These are considered risk factors, and these autoimmune disorders occur more in women. Having your menopause early, under the age of 40 or 45, and even radiotherapy or even some certain chemotherapy drugs for breast cancer treatments are all risk factors for the future development of heart disease. And then, of course, we know the menopause. So the other thing to mention to you is that pregnancy is actually considered to be a woman's first stress test, right? So this stress test is not just for 9 minutes, which is the average duration on a treadmill, but it's actually for 9 months. So pregnancy is a very, very good predictor of the future development of heart disease. So we call these adverse events in pregnancy APOs, okay, adverse pregnancy outcomes. And these include, and you can see on the table on the right, all the different forms of high blood pressure. So pre-existing high blood pressure, so high blood pressure before pregnancy, developing high blood pressure during pregnancy, a more serious form of high blood pressure called preeclampsia, where other organs are involved, like the liver as well as the kidneys. And then preterm birth, I mentioned, so delivery before 37 weeks, really early preterm birth, miscarriage, I mentioned, or small babies, and then gestational diabetes. These are all adverse pregnancy outcomes. And these occur in about 20% of all pregnancies in Canada. And they are, as I've said a few times already, they are associated with an increased risk, which is an up to an 8-fold increased lifetime risk of having a heart attack or a stroke or other vascular or blood vessel diseases, as well as developing diabetes or high blood pressure in the future. And these future events can occur about 10 to 15 years earlier than they would if a person did not have these complications, these APOs during pregnancy. And there's also data to support the fact that there's increased risk of depression in somebody who has an adverse pregnancy outcome. Now, these APOs not only affect the mother, they also affect the children. So offspring of women with APOs are known to develop high blood pressure, or at least increased risk of developing high blood pressure, increased weight, diabetes and heart disease, even as early as in their adolescence. Let me move on to this very, very helpful tool. It's called the FIGO Pregnancy Passport. You can just Google FIGO, FIGO Pregnancy Passport, and you'll get to the link of this very, very handy support. And this is something, women should print out and share with their, um, you know, healthcare professionals, whether it's their family doctors or whether it's their midwives or their nurses. And it asks for, your blood pressure, your weight, all kinds of questions about yourself. But then it also asks about your baby's information from any previous pregnancies. And then it goes through some risks that you can take off. And then it also gives you suggestions on how to manage your blood pressure in terms of diet and nutrition. Of course, you would need to have an obstetrician or a cardiac person or a cardio obstetrician involved in your care as well as, of course, your regular obs-gynae person if you have any of these adverse pregnancy outcomes. Cora, there's somebody who's waiting in the waiting room, if you wouldn't mind admitting them. All
Okay.
right, so make sure you download this form and share it with your caregivers. So now I want to jump to the under-recognized risk factors, and these really are relating to mental health and what we call the social determinants of health. So anxiety, stress, chronic stress, depression, these are all risk factors for the future development of heart disease. And, it's this psychosocial roles as well and behaviors that are imposed by society. And so, I call it being the type E personality or the type E woman. And that's when, you're almost forced to a certain extent because of society's expectations to be everything to everybody every time, right? So you're the cook, you're the caregiver, you are the driver, you have all these responsibilities, plus you could be working, you're cleaning the house, all of these things that many women are felt to be important in terms of their responsibilities in life. And then there are other disadvantages, such as being unemployed or being alone or lonely, not having enough social support, friends, or, communities, poverty, disability, not having, even a high school or university education, and even your postal code, where you live. If you live in a rural area, is a risk factor because you don't have access to healthcare. And then, domestic abuse and intimate partner violence are risk factors. And then, I always say, let's not be colorblind. Our race and our ethnicity and being of indigenous heritage also increase our risk of cardiovascular disease. All right, this is our last poll. Again, I'll read it. Which one of the following statements is true? Heart disease is largely preventable. Or number two, upper abdominal pain or nausea can be symptoms of heart attack. South Asians are at lower risk for heart disease compared to other groups. And then the fourth one is 1 in 5 live births are affected by high blood pressure, blood sugar, or diabetes in pregnancy. And then lastly, number 1, number 2, and number 4 are true. So I'll just stop sharing. Thank you, Corette. Okay, so maybe about 30 seconds more if a few more people could respond. We'd like maybe 12 to 15 responses if possible. I know it might be a tough question, so we'll give you a little bit more time. Okay, maybe 10 more seconds. Okay, so the correct answer is actually what is our 1, 2, and 4. So again, the majority of people responded correctly on that. So that's great. Thank you for doing that. I'll just go back to my slides here. Okay, so moving on to the last sort of third of my presentation, I want to talk about heart attack symptoms. So in both men and women present most often. So this on the left here, this rectangle on the left, men and women present most often with chest pain, but they may describe it as a tightness or a pressure, or a discomfort or even a heaviness. So when somebody describes, a tightness, they also mean chest discomfort. But in women, they have quite often associated symptoms. So women may have nausea or heartburn or upper abdominal discomfort or even upper back or shoulder pain. They may have even profound fatigue or weakness or feel short of breath or feel dizzy or lightheaded. Or they may even feel their heart racing. And sometimes they can have, in addition to this chest pain, they can have even 3 or more of these symptoms. Now, men can also have nausea or these other symptoms, but women present more often with these symptoms in addition to the chest discomfort. And I just want to share this slide, which shows that, for the policymakers that may be joining this webinar, in the 2021 census, the total racialized population in Canada reached, over 10 million people, which was, 26.5% of the overall Canadian population. And the largest racialized group was of South Asian origin, followed by Chinese and Black populations, and then other diverse groups as are shown in this diagram. And there was a 50-50 split actually in terms of men and women in these groups. So it's important for, when we want to develop inclusive approaches in healthcare policy and research, it's really important to understand this information that I've just shared on this slide. And again, the burden is very, very high in South Asians, both in men and women. We have the highest rates of heart disease, high blood pressure, and stroke compared to other ethnic groups. And deaths due to heart attack and stroke occur 5 to 10 years earlier than the Caucasian population. And in South Asian women, diabetes and high cholesterol develop at a much lower body weight compared to other ethnicities. So you don't have to be a person with obesity or a high body mass index to develop these conditions. South Asians have unfortunately higher hospitalization and mortality or death rates, and there's at least a twofold higher risk of diabetes amongst South Asians. And just to discuss this in a little bit more detail, I just want to share some information about, the future. These conditions are not going to go away. You can see on these maps here of the world, the top one is 2015, and red color shows that there are very high prevalence of high blood pressure in these countries that are red. And down here is the predicted. It's a model that the literature in this article uses to predict about, 15 years from now in 2040. When you can see that in certain countries in Africa, like in East Africa, Kenya, Tanzania, South Africa, were yellow in 2015 are now red. So there's going to be more high blood pressure predicted. And then also yellow in 2015 in India and Bangladesh, but it's going to be red. The prediction is that high blood pressure is going to increase in the next decade in these countries. The same with diabetes. This is from the International Diabetes Federation. This data is from 2024, and they're predicting what are the rates of diabetes going to be in 2050. So around the world, diabetes is going to be increasing anywhere from 142% by 2050 in Africa, and in Central Asia by 92%, and 73%, in India and the Indian subcontinent. And right now, 1 in 5, this was one of the polling questions, 1 in 5 live births are affected by gestational diabetes, and this is also likely to increase. So it's really critical that we take these conditions, especially diabetes and high blood pressure, very seriously in our communities, because it's really not going to get better unless we do something about it. And this leads me to prevention. So it's not all doom and gloom. As I suggested before, 80% of these risk factors are manageable, are preventable, and mostly with, first of all, lifestyle measures. So being active, losing weight particularly, keep moving, reduce your portion sizes. So use a 9-inch plate as opposed to a 12-inch plate, and eat more fruits and vegetables, less carbs, and much less red meat. Manage stress with, Tai Chi or meditation, things like that, as well as stop tobacco smoking and vaping as well, stop alcohol intake, and get regular checkups. And even realize, because of the genetic predisposition of the South Asian community to these conditions, even though you may pick up these conditions early, medications may still be required above and beyond lifestyle measures, depending on how much risk is involved, other risk factors, and as well as the severity of the condition. I'm almost done. I think I'm probably out of time, but these are some tips that I like to share with people, because they may not realize that they are in charge. So when you are meeting with your healthcare provider, please prepare for your visit. Make a list of the health concerns you want to talk about, because otherwise you might forget something. But do keep in mind that you may only have time to talk about one thing, so prioritize your concerns, and then go back and see, your doctor or your health care provider about other concerns that you may have. And bring a list of your medications so that the doctor or the nurse can help you right there and then, and not have to call you later, or you don't have to call them back later to see if your medications need adjusting. Write things down, discuss things, but also make note about what decisions you arrived at when you have spoken with your healthcare team, so that you'll also remember and can refer back in your future conversations, and that you'll remember what you need to do. Bring someone with you, a trusted friend or a family member, who can also help you take notes or ask questions. And then if you don't understand, don't hesitate to ask. Ask about what did the healthcare professional mean. Ask for definitions. We use terminology, very, very readily, because it's what we do, but we may not realize as healthcare professionals that the person sitting in front of us, our patients, may not be may not have heard the terminology before. So don't hesitate to ask questions so that we can explain in plain language. So my take-home messages to you are: life, we don't want to miss it. So I hope you realize now that cardiovascular disease is a now problem. It's the number one killer of men and women, and it affects women particularly at younger ages. Adverse events in pregnancy, those APOs we talked about, are risk factors for heart disease for both the mother and the child. And South Asians are at much greater risk of heart disease compared to other groups. Know your risk factors. We've talked about the traditional risk factors, but remember there are sex and gender risk factors as well as other risk factors that are under-recognized. And we can do a lot, a significant amount of improvement and prevention can happen with lifestyle measures. And get screened regularly, and start the conversation, with your children, your siblings, your parents. Really, knowledge is power, and prevention is the key. So thank you very much. I'll stop sharing, and then I'll be happy to answer questions in the question and answer period. Thank you again for your time. And Monica, thank you so much for, your integrity, your honesty in sharing with us, your allyship goals and roles. We really appreciate that. Thank you.
Thank you so much, Shahin, for your insightful presentation and for highlighting the important consideration around women's cardiovascular health. Now it's my pleasure to introduce our next speaker, that's Saleema Allana. She has been a nurse academic for the last 14 years. After being an assistant professor at the Aga Khan University, Pakistan for several years, she moved to Canada and completed her PhD from the University of Alberta, Faculty of Nursing. She has been a tenure track position at the Western University since 2021. Her program of research is aimed at ensuring health equity and social justice for equity deserving groups. such as women and immigrants to Canada. The health science arm of our research program explores the co-creation culturally relevant digital health tools for immigrant women's cardiovascular health prevention and promotion. Her research also explores the translation of equity EDI policies into practice in the Canadian healthcare system. The social science arm of her research program explores the role of technology in immigrant settlement and social integration. She has secured three council funding, AMS Healthcare Fellowship, as well as other external and internal competitive funding, and has been running a successful program of research. Her presentation will discuss the increased risk of dementia among the South Asian women, its link to pregnancy complications, and strategies for prevention. Over to you, Saleema.
Thank you, Gaurav. Thanks so much. I will share my screen. Is my screen visible? Correct?
Yes.
Okay, thank you. Thanks so much. So good afternoon, everyone. Thank you, Kurat, for the wonderful introduction. I'm so pleased to be here today and speaking about this very important topic. I was listening to Dr. Shahin Jaffer, and certainly the points that Dr. Jaffer covered are really important in terms of pregnancy related complications, the risk of cardiovascular disease, and how to manage that risk. The topic that I'll be covering today is about dementia risk in South Asian women and how it is associated with the pregnancy related complications that South Asian women experience during their reproductive years. And I believe most of you would have heard about the term dementia, which refers to the gradual decline in memory in older ages. And this is what I'll be talking about for the most part of my presentation today, and how it is related to your pregnancy and pregnancy related complications. But before I get into my actual presentation, I would like to first acknowledge the land. I am based in London, Ontario at the Western University, and so I acknowledge that we are located on the traditional lands of the Anishinaabe and Haudenosaunee peoples on lands connected with the London Township and Sombra treaties. This land continues to be home to diverse Indigenous peoples, First Nations, Métis, and Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. As an immigrant settler on this land myself, and as a health equity researcher, I'm an ally for Indigenous peoples, and I commit to truth and reconciliation. Also, I would like to present the same disclaimer that Dr. Shahin Jaffer also presented before her presentation. So this presentation is just meant to raise awareness regarding dementia and how it is associated with the pregnancy related complications among South Asian women, but it is not meant to provide any medical advice. And so you're encouraged to contact your healthcare providers in case you need any medical advice in this regard. So these would be kind of the three important things that I'll be discussing in my presentation today. I'll be talking about the increased risk of dementia among South Asian women. I'll also be discussing the association between pregnancy-related complications and the risk of dementia. And then at the end, we'll talk about some of the preventive strategies that could potentially reduce the risk of dementia among women, and particularly among South Asian women. So this is just an overview of the condition itself. And so as I said before, and I'm sure most of you would have heard the term dementia before, and you would understand that it refers to a progressive decline in a person's cognitive abilities, their memory, their thinking and behavior. And this is usually this is a condition that mostly affects older adults. Just to give you a snapshot of how widely prevalent dementia is, about 55 million people worldwide are living with dementia. Um, to consider the gravity of the situation, you could look at these statistics. Like 1/3 of all people aged 85 or older may have some form of dementia, so it's really quite prevalent. In Canada, about 770,000 people are currently living with dementia, but this number is projected to reach nearly 1 million by 2030. So again, it's quite prevalent and rising a lot as well. That's why it's of concern. One more thing which is very important to note is that dementia is not a normal part of aging. What happens is that in many cultures there is a misconception, and sometimes in our South Asian culture as well, that dementia is a normal part of aging, whereas it is not. It is something, it is a condition, it is a pathology, and it can be prevented. It does have some associated factors, and if we do work on those, it can be prevented, but it's not a normal part of the aging process. So, why we want to focus on South Asian women, and why am I speaking with you all today? Who are South Asian women, about dementia in particular. So, research, and I'll be sharing my references in the last slide of the presentation, and so then you can go back and have a look at some of those articles. Research shows that women are at higher risk of dementia as compared to men. And then there have been a number of research studies that have shown a lot of different associated factors among women that put them more at risk of developing dementia in later ages. So, of course, age is a risk factor, but then also menopause, because there's a lot of hormonal changes associated with menopause happening in a woman's body. And then there is a whole lot of research that shows that pregnancy complications like gestational diabetes, like preeclampsia or high blood pressure during pregnancy, number of pregnancies, preterm birth, all of those pregnancy related complications have been shown to be associated with the higher risk of dementia among women. That's why we are more concerned about the fact that women are more at risk of dementia, and that's why we want to prevent it among them. But then also, if one is South Asian by ethnicity, then you have higher, then South Asians have higher rates of cardiovascular disease, diabetes, and hypertension. And all of these are risk factors for developing dementia in later ages. So basically, it's like a South Asian woman has kind of double risk because of being a woman, but then also because of being a South Asian. So all of these risk factors then intersect to increase the risk of dementia among South Asian women. Within the South Asian culture itself, there is diet, stigma, health seeking behaviors. All of those are individual factors that could increase the risk of dementia. So, for example, South Asian diets are often high on salt, trans fats, and often low on greens. In some subcultures, fish is eaten more, but mostly the South Asian diet is low on that. So uh, omega-3, which is and fish, greens are really great sources of omega-3. That is one of the preventive things that doctors prescribe or doctors suggest for anybody who is because it's really good for brain health. So anybody who's trying to prevent dementia in later age, their diet should be high on omega-3. But unfortunately, South Asian diets are low on greens and fish, which are good source of omega-3. And then, of course, diet being high on salts and fats, increases the risk of hypertension, high cholesterol level, being high on sugars increases the risk of diabetes, and then all of these risk factors could contribute in the later life for the development of dementia. A poor awareness and understanding of dementia, as I mentioned before, in many cultures it is understood that dementia is a normal part of aging, and so people do not tend to seek care for dementia, which I think further deteriorates the patient's condition. And then, of course, sometimes there are stigmas associated with dementia, which adds pressure on the patients and the family caregivers not to seek care, because there's a stigma associated with that particular condition. So all of those cultural factors also play their part in putting people more at risk of dementia or of having worse outcomes as part of dementia. Um, and then, of course, there are barriers in the healthcare system as well, which not only pertains to dementia, but to any care. We do have certainly, lack of culturally relevant care, which affects people of all conditions, but more so racialized populations are affected more by limited culturally relevant care. So in this slide, what I want to portray here is what I already talked about briefly in the last slide, that if you are a South Asian woman, then you have two intersecting identities that are actually doubling your risk of dementia. So women already have a 50% greater risk of dementia than men, as we already discussed before. And then also, being a South Asian confers a greater risk of dementia due to all of the increased risks of these risk factors as well. But then again, when these two risk factors intersect with each other, and when one is a South Asian woman like myself, our risk of having dementia in later life substantially increases because of these intersecting social identities or these intersecting risk factors. And that's the reason why we are concerned about this, and we are talking about this today to you all. These are some of the statistics, because since the beginning of this presentation, I have talked a few times about the pregnancy related complications and that how they are linked to dementia. But this slide kind of gives you some concrete numbers to look at how various pregnancy related complications increase the risk of dementia. So if one has had 5 or more complete pregnancies, their risk of Alzheimer's disease or dementia increases by 1.7 fold. If someone has had preeclampsia, which is high blood pressure during pregnancy, which many of the South Asian women, experience during their pregnancies, then for those women, their risk of young onset dementia. Now, young onset dementia is when someone develops the symptoms of dementia before the older age. So the landmark of 70s and 80s, where usually the dementia hits. If someone develops it before that, then that's young onset dementia. And women who have had preeclampsia or high blood pressure during their pregnancy, they have a 2.65 fold increased risk of young onset dementia as compared to other women. Those women who have had gestational diabetes, just like Juhi was describing her situation, they of course they are at increased risk of developing type 2 diabetes later in life, and then also their risk of dementia increases by 67%. Women who have had preterm birth or low birth weight as part of their pregnancies, again, that is linked to or that is associated with maternal cognitive decline or dementia in the later years of life. So that is just a few numbers or a few research statistics to show you the gravity of the situation. Again, this is a slide courtesy of Dr. Shahin Jaffer. Thank you, Shahin, for sharing this slide with me. This slide actually shows the various causes of death among women and men in Canada. So these are the causes for women, and these are the causes for men, on the right. On my left, if you look at the causes for death among women, the very first one, and the number one cause of death for of death among women in Canada is Alzheimer's disease and other dementia. So dementia is really right now the number one cause of death for women in Canada, and this is certainly something worrisome. And we should be working towards, preventing this, to be able to prevent mortality or death among women in Canada. Well, so here are a few preventive strategies that could, and this is no different than, any healthy lifestyle strategies. I think some of those Shaheen has already shared as part of her presentation as well. But these lifestyle modification or these healthy habits would help prevent dementia in later life. For Could prevent for South Asian women, for those women who have been through pregnancy related complications during their reproductive years as well. So first of all, lifestyle modifications like diet and exercise. As we talked about, diets high on salt, diets high on sugars, diets high on trans fats, all of that could lead to the risk factors of dementia, that is high blood pressure, diabetes, increased cholesterol level. If we control all of those factors in our diet, and we could control those risk factors, then we could potentially prevent the risk of dementia in our later lives as well. Exercise certainly has been shown to negate the increased risk of dementia in women in general, but also especially among women who have had gestational diabetes or other complications of pregnancy. If you are, by any chance, you do have hypertension, diabetes, or cholesterol, then by all means try and control your hypertension, diabetes, and cholesterol by controlling your diet, following your medication regime strictly, and of course through exercise. um, and as we discussed before, South Asian women certainly are at greater risk for all of these risk factors. So we really need to put in more effort towards these preventive strategies. Early screening for cognitive decline is also something that one should consider. If you feel you're, having symptoms, it's always good to, even if you are not that age, it could be a young onset dementia. So one should, always try and have oneself screened for cognitive decline with your um, general physician, your family physician, or if you do not have one, then maybe at a walk-in clinic. Um, Monitoring of South Asian women post pregnancy with complications. This is again something very important. And I know that at the Canadian Women's Heart Health Alliance, we have talked a lot about this, that, we do have women from various racialized ethnic minority backgrounds, just like South Asian women, who tend to have a lot of pregnancy related complications. And so we need to have a system established whereby we could follow these women after they give birth to see what kind of complications they are developing and how can we prevent those complications among those women. But this is something which is system related, and we are certainly working over it. But you, as an in charge of your health, if you think that if you know that you have had gestational diabetes or preeclampsia or any other pregnancy related complications, then do ask your healthcare provider to screen you further. Community-based health education tailored for South Asian women is something what we are doing right now, and we plan to keep doing this, continuing to do this. uh, we all should address the stigma around dementia in South Asian communities. We should play our part. And then Canadian Women's Heart Health Alliance produces resources in several different native languages. So you can always contact us for resources in your language that you speak. This is just a summary of what we discussed today. South Asian women are at higher risk of dementia, pregnancy complications put you more at risk, and lifestyle modifications can prevent you from the longer term risk of dementia. These are my references. You can always go back to them and read them. And thank you for listening to this. And I hope that with today's presentation, you must have got some key points to take away from this, to take back home and start working towards that. Thank you so much.
Thank you so much, Saleema, for your informative presentation and for sharing valuable insights on the dementia risk and prevention among South Asian women. Now I will request Monica Perry to share information about the recruitment for the Crowning Us project. Over to you, Monica.
Thanks, Kirat. I'm just going to share my screen again. And thank you to the presenters. That was wonderful. I hope you can see my screen. And I'm just going to put this, we've looked at this slide already. I just want to remind people what Crowning Us is. Cardiovascular risk across the lifespan with women, intersex, gender diverse, and other underserved people in Canada. We are a Canadian initiative focused on equitable cardiovascular health, centering on women, intersex, gender diverse, and underserved populations, promoting health across the lifespan, and challenging gaps in representation, treatment, equity, and bias. So we aim to share knowledge, and today we had a couple great presentations and some shared experiences about some of those risks in women, and specifically in South Asian women. Now we really want to build capacity to improve outcomes and try to sort of change the trajectory that Shahin presented, where it's been on an incline, I think, since about 2011. So we would again like to invite people to work with us to help us learn what are the priorities for moving forward. And again, we just focused on one small snippet today on pregnancy, but you can see there's many other things that could be priorities for us to work on. We are trying to sort of host a workshop, and in this workshop in February, we really want to hear the voices and what are the priorities moving forward for us to change this trajectory, especially in the South Asian population. Sorry, I want to now share a couple posters with you. This one and thank you to Lisa and the Canadian Women's Heart Health Alliance, who has been partnering with us from the outset. They're an organization that is based in Ottawa. They've been doing a lot of work on women's health in Canada since, I might get this wrong, but around 2018, I think. Have a lot of resources, but really need to build some resources focusing on other populations. So this is an English poster, but we actually have translated the posters for sharing in other languages and would welcome you to share within your networks so we can help sort of change this target. So these are just a couple posters, happy to share, and I would suggest that perhaps reaching out to Kirat or Lisa. And I'll just stop sharing, and that's really what I wanted to end with. And I think now, Kirat, if you want to just speak to CASSA, I mean, we're fortunate enough to have your support through all this work, and thank you very much. But maybe just highlight what CASSA does, and then we can look at some questions for our panel members.
Sure, Monica. Thank you so much. Just as a reminder, please feel free to send your questions. We'll be closing the chat soon. So yeah, please feel free to send your questions as soon as possible. As a reminder, I am Kuratulan, the Executive Assistant and a Membership Coordinator at CASSA, the Council of Agencies Serving South Asian. So we are usually known as uh, a social justice umbrella organization. We have over 120 member organizations that offer direct and indirect services to the South Asian and other racialized communities. These organizations provide a range of services, including social service, health related service, educational support, cultural service, and much more. At CASSA, we serve our member organizations through advocacy, research, capacity building, training, and development of resources. And I would like to thank Monica for keeping CASA as a partner on this project. It's an amazing experience. And yeah, I will share the flyers and other recruitment with the attendees after the session. Over to you, Monica. And now we will be starting our Q&A session. Oh, Monica, you are on mute.
Yeah, thank you, Kirat. And thank you to Shahin and Saleema and to Juhi. So we do have a question in the chat, and I would urge people to post. And Kajia, thank you for this question. And the question is probably directed to you, Shahin, most appropriately. Will risk increase in late life pregnancies, or will IVF, in vitro fertilization, in women who have hypertension? That's a good question.
Yeah, for sure. It's not a question I get usually, so that was great. But yes, of course, even without any family history or previous history of these adverse pregnancy outcomes, as we get older, the risk of developing high blood pressure, diabetes is higher, and particularly with IVF because there are, often multiple gestations like twins or triplets, what have you, and the risk of developing high blood pressure is as well higher in that. So you might even consider being older and having IVF as additional risk factors for the development of any of these adverse pregnancy outcomes. So it has to be aggressive pre-pregnancy, and really when you're thinking of conceiving, that's when you really have to start working hard at getting the weight down, getting, if you have pre-existing high blood pressure or diabetes, really, really being aggressive and getting to your thresholds and your targets that your healthcare providers will be able to assist you with. So pregnancy is not just starts when you conceive, but it starts several, maybe even up to 12 months prior to get everything under the best possible control as possible. Yeah.
Thank you,
That
Shahin.
helps. Yeah.
Yeah, thank you. There is another question, but before we go there, Juhi, I want to ask you a question if I might, and thank you so much for sharing your story with our group today.
Yeah.
So, I'm interested to know what you were told prior to your second pregnancy, which happened very close to your first pregnancy, and your history of high blood pressure during your first pregnancy, and then what you were told after your second pregnancy in terms of risk or follow-up, etc.
Yeah, so my physician, she made sure she regularly checked me up for like 3 months after I delivered. First month, of course, after postpartum, I had to bring my baby as well. They also checked my baby's things as well, like uh, pressure and all those stuff for me as well. And they checked me for like first month and 3 months and then 6 months. And after delivering the babies, everything went normal in my body. But my gynecologist and my physicians, we were in Alberta, and they both were they made sure that I was back to normal after delivering the baby.
And were you told about any sort of ongoing follow-up? For example, in 10 years, as you get older, what sorts of things might you?
So now, like, I just get myself checked like every 6 months or yearly, a full physical and like my blood work and everything. I have a thyroid, so I have to get it checked anyway. So I always follow up with doctors and make sure my like diabetes and like everything, like my blood sugars and my blood pressures and everything is normal.
And were you told anything about your babies? Because both babies.
Babies, I also take appointments for my babies as well, but they're normal. They're normal so far. They're okay.
Okay. I mean, we sometimes forget that they're at risk too, and not just we're at risk. So thank you for that. So that kind of leads nicely into the question posed by Rita, and it is more related to postpartum. What postpartum follow-up strategies or screening tests should be followed to protect cardiovascular health? Sheen, I don't know if you want to take that one
Sure.
again. Maybe
Actually, you know what? I'm just going to share screening because I was just while the last question was being answered, it's a great question. So I hope you can all see my screen now, right? So this is a slide I often use when I give these presentations. And so postpartum is also known as the fourth trimester, right? From delivery to 3 months postpartum. And so these are the things that I think will help answer the question. So on the left-hand side, you have starting at 1 week postpartum up to 3 months and beyond postpartum. So if somebody, wants to take a snapshot, sorry, I don't know who asked the question, but this is, and the references at the bottom. So you want to make sure that everything, is assessed by yourself and your healthcare provider, all the way from your vitals, your blood pressure, etc., your mental health. How are you doing yourself nutritionally or in your breastfeeding, etc. And then get the counseling as it shows in the middle. Start getting more active, and again, working at trying to lose the weight you may have gained. Talk about to your health provider about those APOs and the long-term risk, especially if you want to consider another pregnancy. And then also treatment is important. So get referred to a counselor. If you're not thinking of conceiving again in the near future, go on the medications that you need to, like if you're not also nursing. So maybe, in a few months' time, but start talking about these concerns right, in the postpartum period. And particularly mental health, as you know, there's postpartum depression, and, we need to seek support for that sometimes. I hope that helps.
Yeah, thank you, Shahin. Saleema, and I really thank you, Shane, and I like that visual. I think visuals are really powerful, so thanks for sharing that. Saleema, I have a question I've been wondering about for you, and that you spoke a lot about culture in your presentation. And I just wonder, given what we learned about risk factors today, how can or what can South Asian women do to feel empowered to manage the risks? Because I think there might be some differences, and we need to sort of think about those.
Yeah, yeah. No, thank you, Monica, for that question. I think as part of my research, when I work with, racialized women, specifically South Asian women, those kind of questions, often come up. And I think the way to look at it is that, when we talk about care for these women that we are talking about, it is self-care and family caregiving is an essential part of the care, in addition to the clinical care that the clinicians provide. And so I think this big part of the care often is overlooked, and which should be emphasized. For the self-care, the women should be taking charge. As you asked, in terms of the risk factors, and how to prevent risk factors and how to prevent the risks, I think a major role comes in when a woman takes the charge of her own health, and takes the responsibility of self-care. And that entails all of that some of the things that Shahin talked about as well, that going to your appointments with a prepared list of questions, knowing exactly what do you want to discuss with your physician. And many a times, being a racialized woman, you have to advocate for your own self within the healthcare system to be able to get the right care that you deserve. The other part of it, as I said, is family caregiving. And I feel in the context of South Asian culture, family caregiving is very embedded, because caregiving is seen as a shared family responsibility, whether it be any condition. And so many of the pregnant South Asian women, they are being closely taken care of by the family caregivers. And so a lot of diet related things, for example, could be managed if the family caregivers are appropriately educated about what kind of diets to be avoided and what kind of diets to be added to their diet while they're pregnant or even postpartum. So I think those aspects are really important to be looked at.
Yeah, thank you. I think the important point is the self-care at the individual level, but also the perspective of the healthcare provider, sort of
Yeah.
thinking about those nuances. And I think about, you've focused a lot on following diet, exercising, but foods are expensive for some people, and time to exercise or safety to exercise are really important. So um,
Yes.
I feel that we probably need to educate both the recipient and also the healthcare providers in a
Yes.
good holistic approach to care.
You're right, Monica. Those are the barriers, and certainly there needs to be some interventions that need to be done in that regard at the system level or at the healthcare providers level. But at the individual level, you very rightly said that the education needs to go about at both ends. So at the individual level, the least that we all can do and should do is that I know that the food is getting really expensive, but we could still make healthier food choices as compared to more expensive food choices to get the same amount of nutrients that we would get. So for instance, meats are a good source of proteins, but then also lentils are much cheaper but then are also a good source of protein. Similarly, greens are much cheaper, but they are a really good source of some of the great vitamins and omega 3. So those kind of choices. And then also I know, being a South Asian woman myself, how family caregiving work, everything, when it's so it becomes so difficult to exercise. What I recommend to people around me and I try to do is integrate your exercise with the other responsibilities. So for example, if I'm taking my kids to the park, I would try and walk there as well, so then I could kill two birds with one stone. So I think those kind of things could creatively be done.
Yeah, thank you for that. And Shaheen, I see you posted in our discussion about some other places where one might get some good foods that may be more.
Yeah.
Yeah.
Yeah, so I don't know if they have the BC Farmers Market here in BC, have this discount program. I'm not sure whether somehow you have to, how you prove that you're of low income or what have you, but anyway, it's a good resource for many people. And then the other thing, just in terms of the exercise, I know it's tough, and during COVID-19, and I still share this with my patients, I say, look, make your house your gym. Climb your stairs intentionally for 5 minutes every hour, or do the laundry, volunteer if you have time, do the vacuuming, do things like that, because all just getting your heart rate up, they all help reduce those calories that we tend to overeat.
Yeah, that's it. I had a student that actually looked at exercise, and she was South Asian, in the South Asian population, and specifically women, and she embedded, using soup cans and cans in the kitchen where you could do some resistant training as you were
Yes.
preparing dinner and stuff. So you have to be in sort of
Yeah.
thoughtful here. So I just will check for final questions. It doesn't look like there's any final questions. We're sort of at time. I don't know if there's any final comments as we leave. But again, thank you very much. And thank you, Kirat and Lisa, for supporting this initiative.
Thanks, everyone. Bye.
Thank you, Monica, for this opportunity. Thank you, everyone, for being here.
Sorry, Shahin, can
Thank
you
you.
share that resource in the chat?
I did. I put it in the chat.
Can
It's
you
the
screen share?
BC. Yeah,
Can you share that?
it's there in the chat with the link.
Thank you for attending too, everyone.
Yeah.
Yeah, and as we conclude today's session, I would like to extend my sincere thanks to our speakers, Shahin, Jaffer, and Saleema, for sharing their expertise and valuable insights with us, and to Lisa for managing tech and screening questions. She's at the back end, but thank you so much. And Monica for help us organizing this, moderating the question Q&A session. And thank you all for attending and joining us today. The session recording and the resources, including Saleema's presentation, will be available soon on CASSA website, and as well as I will share with you guys via email. But we really appreciate your time, and we are looking forward to see you in our future session. Thank you, everyone, and have a great day.
Thank you, everyone.
Bye.
Thank you. Bye.